All right, so to continue our discussion on the assessment of respirations. The ventilations are assessed for not only their rate, but their depth, their effort, and their regularity. Just like when we talked about the pulse is not strictly the number. The number doesn't tell it all. The number itself is a way to quantify the rate of ventilation or pulse, either one. But it's the additional characteristics, such as are they able to take a deep breath or is it very shallow? Are they struggling to get a breath in? Is it nice and easy for them to move the breath? And then that regularity, that respiratory pattern that they have that helps tell the entire story. We know that for an adult, the normal or the average adult respiratory rate is around 12 to 20 breaths per minute at rest. It's regular in rhythm. It's effortless. And the depth itself is it's noticeable that they're moving air in most cases, but not overly obvious that they're moving air. So in some cases, we're talking about patients who have heavier clothing on, bulkier clothing on. It may be more difficult for you to actually see their chest rise and fall, but that gives us the information on depth. So some things we're looking for with respiration is the minute volume. And that minute volume is calculated as a tidal volume versus the respiratory rate. This topic keeps coming back up, so it must be somewhat important. But the tidal volume is how much do they move, tidal volume is how much do they move in one breath. The respiratory rate, of course, is how many times per minute do they do this. So if we take the total that they move in one breath, multiply it times the number of breaths per minute, that gives us our minute volume. So they give you an example there. And then of that, we have to understand that we have a functional capacity or a functional volume there. That of that 500 mils per tidal volume or per breath, only 350 of that reaches the alveoli and the bronchioles. We have 150 milliliters of approximately 150 milliliters of anatomic dead space. And so remember, that's trachea, that's bronchi, that's larynx, pharynx, all that. Those areas don't do gas exchange. They have air in them, but that air cannot be used per se to oxygenate blood. So note if the patient is using accessory muscles. This kind of goes along with detecting their effort. So this kind of goes along with that. The work of breathing, increased work of breathing, I guess is another way to put this. So if they have something like tripoding, they have abnormal noises with ventilation, so they're grunting. They have signs of respiratory distress. These sorts of things that they're working extra hard to move air in and out. So obtain your respiratory rate, observe the depth and rhythm of the ventilations, and observe that chest rise and fall. Those are all things that we're looking for specifically when we're assessing a patient's ventilations, as I like to say, although appropriately it's referred to as respirations, but like I've mentioned before, that it's hard for us to actually determine whether or not they're actually respirating, but we can see that they're moving air in and out, which is ventilating. So a couple of breathing patterns. I think these have come up before. If you haven't started to commit these to memory, it would be a good idea. Eupnea, EU. When we use EU in many medical terms, EU generally means normal, average, regular. So that's kind of the status quo. So eupnea is a normal breathing rate and pattern. Tachypnea, tachy means fast, brady means slow, whereas hyper and hypo mean bigger and smaller. So tachypnea would be an increased respiratory rate. It can be caused by fever, anxiety, shock, exercise, lots of things. Bradypnea is a decreased respiratory rate. Sleep, certain drugs, certain metabolic problems, head injuries, strokes can decrease this. Apnea, when we put an A or an an in medical terms, that usually means without, so absence of breathing. Hyperypnea, this is a normal rate but bigger respirations. So this is not to be confused with hyperventilation. Hyperventilation is increased rate and depth, but hyperopnea is a normal rate, but a deep respiration. So they're really moving air in and out quickly, or not quickly, heavily. Cheyne-Stokes, this is a gradual increase and then decrease in respirations with periods of apnea. So this increasing intracranial pressure or a brainstem injury usually is a reason to see this. Now, with that being said, Cheyne-Stokes is not always something that we immediately see in the patient who's suffered some sort of a brain injury or a neurologic injury, simply for the fact that, and sometimes it takes a while for the body to kind of sort things out and adjust. So it's not always something you're going to immediately see in the field, but in many cases when you go to, say, transport somebody, you might see this. You might see people who are going, say, from the acute care hospital, the trauma center or whatnot, and being transported to, say, rehab, and you might see this. If you need a graphic or a visual interpretation of this, don't forget you can look at page 386 in your textbook. And it kind of has basically the same chart, except with a picture representation of how these might look. So, BOs, people call it biots, but it's BOs. BOs respiration. These are deep, they're rapid, almost gaspy-like, with short pauses in between the sets. So it's kind of a almost like they forget for just a minute to pant. Kussmaul's, these are hyperypnic and tachypnic, or what most people would refer to as hyperventilation. But Kussmaul's, very fast and very heavy respiration, common in people who are acidotic, so metabolic acidosis, diabetic ketoacidosis, renal failure. The BOs and the Cheyne-Stokes really, and then the next one, apneustic, those all really lean towards a neurologic issue, usually a structural neurologic issue. And then apneustic is prolonged inspiratory phase, shortened expiratory phase, but in reality, it's really just kind of all over the place. They maybe breathe deep, they maybe breathe slow. It's just kind of all over, and I recommend you look at 386 and take a look at the kind of the graphic representation. So additional things to assess respirations: abnormal upper airway sounds, snoring, gurgling, and stridor being our main ones. Snoring, of course, from the tongue, partial occlusion of the upper airway, usually by the tongue. It's the soft tissue that kind of flaps in the breeze, if you will. That gives us the snoring respiration, or sonorous is another way of putting the sonorous respiration. Gurgling is an indication of fluid in the airway. We're trying to bubble air or gases through a liquid. I mean, just like if you put your blow through your straw into your soda or whatever you're drinking, you get gurgle, gurgle. I mean, that's the exact same thing. Stridor is a high-pitched sound that is indicative of a partial airway obstruction. This is usually not tongue-based obstruction. This is usually a foreign body and or swelling of that upper airway. So the most common place to hear that is some blockage right at the vocal cords or the epiglottis. So you may have a very swollen epiglottis that's leading to some stridorous respiration. We're also going to take a listen for lung sounds. And lung sounds get auscultated using the stethoscope, of course. And that normal air movement and abnormal breath sounds are things that we're looking for. The things we typically are hoping to hear is just kind of a general, nice, easy movement of air in and out. There may be just a very slight sound to it, just simply because it is there is some air movement, just like wind. But it's when we start to add other things to it, such as bubbles and crackles and music and so on and so forth, that it makes it a little different. So crackles or rails is the other name for this. Rhonchi, and then wheezes being our major lung sounds we're concerned with. There are some others, but these are the major ones. I mean, things like a friction rub that you may occasionally hear in there where it's actually kind of a dry grating sound. Crackles are fine bubbles, little bubbles in a thin fluid, so kind of a fizzing, that cracking of a soda can or a beer can that you hear. That's kind of a crackly sort of sound. You can also take, if you have hair long enough, bring that down in front of your ear and just kind of roll your hair back and forth between your finger and your thumb, and it gives you a similar sound. So these are often fine amounts of fluid that's built up in the lower airways. So maybe you have collapsed alveoli or the terminal bronchioles in which air has to try to move through. So sometimes you'll have a little bit of crackling simply from the patient having what's referred to as atelectasis. And atelectasis is the collapsing of certain alveoli that are just not in use. Sometimes a deep breath takes that away. Pulmonary edema, so people with congestive heart failure typically have the crackles or the rails. Rhonchi, lower pitched, rumbling, heavy, thick secretions, larger airways, bigger air bubbles moving through them. It's like a pneumonia patient. When you have a lot of mucus in your throat from sinus infection or something like that, think of that as kind of being the source of where that comes from. And then wheezes, kind of a high-pitched whistle or a musical sound to it. And this is usually from constriction of the bronchioles, the little bit larger bronchioles, not usually the terminal bronchioles right at the alveoli, but the little bit larger ones. These are both, this comes from both a constriction of the muscles and from a increased secretion. So you get some edema or some other mucus that builds up in there. So it's kind of a twofold where that wheezes comes from. So we'll document them appropriately, whether we have they're clear and equal bilaterally, or we have wheezes on the left side. Maybe we have rhonchi in both bases or both lowers. We have crackles in both uppers or both apices. So we note that. Then you listen side to side. The recommendation for listening to lung sounds is actually to do it in a Z pattern, a Z-shaped pattern. So when you listen to, we'll say the right upper, then you move your stethoscope over to the left upper. And then you move your stethoscope down to the right lower, and then you move it over to the left lower. So we're able to compare left and right. I guess it wouldn't absolutely be wrong to do, say, a C shape, just as long as you were comparing right and left right next to each other. That would be the smartest way to go about that. And then we can move on to skin temperature and body temperature. So skin temperature gives us a general indication of body temperature. However, on a day in January where you've come in from being outside, it's cold, maybe it was a fairly long walk from the ambulance into the house, and you didn't have any gloves on, or you just had your exam gloves on, and you walk in and, oh wow, everybody feels warm in here. Well, duh, you acclimated, not fully, but you acclimated to the outdoors, so it's going to throw you off. So it's not as accurate. Kind of like if you remember maybe when you were a kid, when they took your temperature, they didn't want you to have had anything to eat or drink in the last 5 to 10 minutes before they take your temperature, for the simple fact that it will alter that environment temporarily. If we had, say, a temperature port in our body that we could stick a probe all the way into your, I don't know, your liver or the middle of your intestines, that would give us a more true body temperature, that would not be such an issue. But our average normal body temperature orally is around 37 degrees Celsius or 98.6 Fahrenheit. This varies from person to person. Again, these are average. When we have a fever, it's usually as a result of an infection, sometimes from a blood transfusion reaction, which is body kind of looks at as a infection because it's foreign material. Medication reactions and hyperthyroidism. People who have hyperthyroidism are pumping out the metabolic hormones and keeping the metabolism running really high. So therefore, it tends to they burn off a little more. It's kind of like, your car gets a whole lot warmer when you're going down the road at 80 miles an hour, as opposed to if you're driving around town at 15 miles an hour. The body warms up that much quicker when it's got more stuff pumping through it. So the following terms, hyperthermia, hypothermia, and hyperpyrexia. So fever or pyrexia, which they don't list on here, a fever or pyrexia, we hear antipyretics. Yeah, those are for fever. So things like aspirin and ibuprofen, acetaminophen. So pyrexia is an elevation of the body temperature above normal. And that fever is generally caused by an infection or from some really internal, in most cases, issue. Hyperthermia is usually used to refer to an increase in body temperature because of our environment. The same is correct with the same is true with hypothermia. So generally when the environment is too hot or too cold, we end up with a hyper or a hypothermia. Hyper for hot, hypo for low or cold body temperatures. It causes changes in the way our body responds, whether we're vasodilating, vasoconstricting, or what have you. Now this other term, hyperpyrexia, so fever is not considered medically significant unless it's above really 100 degrees, so, or 38 degrees Celsius, to be exact, 100.4 degrees Fahrenheit. Treating low-grade fevers is not always something that we're quick to jump on, but you got to treat any fever that is above 40 degrees Celsius or 104 degrees Fahrenheit, particularly in the adult. Adults just don't do well with that high of a fever. Kids can deal with that for a little while. Hyperpyrexia, this is an extreme elevation in body temp, so where we're above 40.1 Celsius or 106 degrees Fahrenheit. This is really kind of that 106 mark there is really kind of a point of where it becomes a life threat. So they're taking an oral temperature here. Trying to tell, it doesn't look to me like they actually have a sleeve on that thermometer. Most of those style thermometers have a little plastic sleeve you put around it, makes cleanup a little easier. The older glass thermometers, they contained mercury, they were not particularly safe, and they took a long time to register. So it kind of was prohibitive for us to do those in the olden days. Nowadays, with digital thermometers that they'll read in Celsius, they'll read in Fahrenheit, they'll read in both. We can hit a button and it converts it for us. And they're quick. Some of them are taking 10, 15, 30 seconds to register, whereas the old glass style thermometers, it was a couple of minutes. It took a couple of minutes for the mercury to register on the thermometer itself. So the oral or the tympanic, rectal, or axillary temperatures, we have forehead thermometer strips, all kinds of different ways to do this. Really something that probably needs to be discussed with the medical director, the medical community to see, really truly what's the best way to go with this. The tympanic thermometers, where we're kind of running them across the patient's head, they're great, but they're expensive. We're not always good in EMS of taking care of our equipment. So if it's something that we're likely to lose, it might be a better idea to go with a little less expensive piece of equipment. It's not like they're big like a cardiac monitor that we're going to obviously see them. There's a temperature conversion table. If you really want to know how to convert it, Celsius to Fahrenheit, you multiply 9/5 to your number. So whatever your Celsius number is, multiply it by 9/5, or multiply it by 9, divide it by 5, and then add 32, and that will give you your Fahrenheit. So we'll take, for example, if we take 35 right there, 35 times 9 equals 315. Divide it by 5 gives us 63. We add 32, and it gives us 95. Okay, so that's how you can get to that. To do it the opposite way, to go from Fahrenheit to Celsius, you take your Fahrenheit number. So we'll take the same thing again here. We'll take 95. We'll subtract 32. So we're basically doing this in just complete reverse. So you subtract 32, and then you multiply that number, which is 63. We'll multiply that by 5, which gives us 315. We'll divide it by 9, and that gives us 35. So that's the way you can do it. Hopefully, if you're going to do temperatures, you've got one thermometer that just does it easy for you. Okay, so EMTs Matt and Marcy are on the scene with Mr. Haynes. He's a 42-year-old man complaining of a sudden headache. Okay, Marcy says, I got a pulse of 72. It's regular and strong. Respirators are 12, and the depth is good. I'll help them get ready to transport while you get a quick blood pressure and pulse ox. Okay. So assessing the skin, we're going to check for things such as color, moisture, temperature, mobility, turgor, and these sorts of things are sometimes thrown in as a quote-unquote vital sign, where they'll talk about skin vitals, and I think it's an appropriate way to refer to them. It's not just understanding that it's not technically a real, true vital sign, but it does tell us a lot about our patients. So checking all the skin gives us a good reflection of what's going on within the body. So when we're looking for things such as color, they may be normal, and normal can be difficult for us to define, because if we don't know the person, it's hard for us to say whether they're pale or not. So they may be pale or have pallor. They may have redness or be flushed. They may be cyanotic, or the blue tone. They may be jaundice, which is the yellow tone. There's also a couple of others that kind of get thrown in there, things such as mottled, and then there is another one that gets referred to as ashen gray. So ashen, usually or sometimes referred to as dusky, but kind of a general pallor / cyanosis mixed together. The mottled skin tone, it usually looks like marble, so kind of a marble look to their skin. So it's kind of, there's some kind of pinkish areas of it. There's some kind of white splotches, and it's very, a very irregular pattern to it. So we're also looking for that excessive dryness or sweating. Excessive dryness is not always a big deal. I mean, particularly in the wintertime, where a lot of people have very, very dry skin. Sweating, they may be diaphoretic, which is usually hot and sweaty, or they may be clammy, which is cool and sweaty. So those are some examples there. We got a couple more of those we're going to talk about here in just a second. So diaphoresis can be present in shock, as can clamminess, and MI and other issues. So possible skin findings. So when we have pink skin, normal skin in color for lighter-skinned individuals, the normal color of the mucous membranes in all individuals. So whether we're looking inside the lip, so kind of inside the mouth between the lip and the teeth, we can look at that. We can also look at the conjunctiva, where we will look at, kind of pull down on their lower eyelid and look at the color of that. It's a good places for us to find the skin coloration. Pale, this is usually some constriction of the peripheral vessels. Shock, fright, being cold, those are all things that can cause you to become pale. Cyanosis is from hypoxia. So when we have low oxygenation, for whatever reason, whether it's a ventilation issue or a respiration issue, an oxygenation issue, or poor circulation, that can lead to cyanosis. Flushed or reddish skin comes from fever, exertions, hyperthermias, excitement, embarrassment. It can be things like people with excessive hormones flushing their body, so perhaps something like person with hyperthyroidism. There we go. That's what I was looking for. So, and then with jaundice, jaundice is almost always a liver issue. There's a difference between people having something called hyperkeratinemia, meaning they have too much carotene or beta-carotene in their system, which comes from eating a lot of carrots. Their skin will be yellowish in color or orangish in color, but their eyes will not be. Their eyes will be remaining white. When they're jaundice, everything is yellow. So the whites of the eyes, the sclera, or the have this yellowish coloring to them, or what we call icterus. And then the mottling. This can be exposures to cold, excessive exposures to cold, shock, people in cardiac arrest. Those sorts of things can become mottled. Additional things that we might look for: cold skin and hypothermia and poor circulation, cool skin, and shock, fright, anxiety. Also, it kind of depends. They may be just, it may be in relation to their circulatory status as well. Maybe they take certain medications. Warm is fairly normal for us, and if you're going to really truly consider their skin temperature, you really need to check it from the core. So checking the back of the hand or the forehead, which is constantly exposed, is probably not the best way to do this. Hot skin would be from a fever or hyperthermia. Dry, it's normal for skin to be dry, but excessive dryness could be dehydration or hyperthyroidism. Moist skin from fever, exertion, hyperthermia, shock, fear, anxiety. And then poor mobility, or the skin is very tight. So that would be something like edema or swelling. They have swelling in that area for some reason. It's causing the skin to kind of become taut. And then poor turgor, which this is the skin lacks elasticity. I kind of am not a big fan of this offhand, because people who have been heavy and have lost weight have poor skin turgor. People who are elderly and have kind of lost some of their mass have poor skin turgor as well. So it's not a very reliable way to look at it. But if you pull up on the back of their hand something we call tenting, so you grab some of their skin and you just pull it up right, and in most cases it snaps right back down into place very quickly. Sometimes if it stays tented up like that, we say that they have poor skin turgor, but you have to take it with a grain of salt. Another good way to assess for dehydration is have them open their mouth and stick out their tongue, and if it's cracked and furrowed, like the dirt in Iowa in the end of July, where it's so stinking dry, it's cracked. That is probably a better way to consider that person's hydration status. So here again, they talk about tenting it up, like I mentioned. So that mobility is the ease in which that fold of skin can be lifted, and turgor is the speed in which it goes back to its original position. So it's kind of 6 of one and half dozen of the other. Assessing pupils. When we're going to look at the pupils of a patient, we have something like, we generally consider people to have normal pupils that are roughly about 2 to 4, 3 to 4, depending on the person, millimeters in diameter is normal. Or kind of, when I think about it, I try to think about, let's see, what's the size of a regular old pencil eraser, and being somewhere between there and the size of a pencil lead. That's an old wooden yellow number 2 pencil. When we get much bigger or much smaller than those, that's where we start to get a little concerned. So we may have very constricted pupils, which are generally smaller than, say, 2 to 3 millimeters. We may have very dilated pupils, which tends to be bigger than, say, about 5 or 6, 7 millimeters, where it takes up a majority of the eye. The pinpoint or the constricted pupils tend to be, you almost miss them from looking at them. So this shows us a couple things here. We have constricted, we have dilated, we have unequal pupils. Unequal pupils in many cases is seen as a sign of a structural issue within the brain. However, there is a large portion of the population that has something called anisocoria. And you can find that on 468 in your textbook, where they have slightly unequal pupils. And sometimes it's more than slightly. Sometimes it's more of a 2 or 3 millimeters, but it's usually something that the patient is well aware of. So if you were to ask them if they have normally unequal pupils, most of the time they would be able to tell you, oh yes, I have. They may not know the term anisocoria, but that's the kind of the norm. So the pupil, that is the black part in the middle or the center of the eye, so that's the opening, whereas the iris is the colored part. So it's the blue, the green, the brown, hazel color to the eye. That's the iris that adjusts, and that makes that pupil bigger or smaller. So it's actually the iris, size of the iris is what we're really looking at, because the pupil really isn't, quote unquote, something. It's a lack of. So there's no tissue covering it, so you have a bigger pupil. The size of that pupil gets controlled by oculomotor nerves and sympathetic nerve fibers. There's a few things that influences pupil size. Certain drugs, for example, most drugs will not cause the eye to constrict. It's more commonly, if we have very constricted pupils, it's usually a sign of a narcotic drug. So we're going to get to that in a second. So the pupils are going to be determined by the balance of sympathetic and parasympathetic input. Sympathetic generally causes our eyes to dilate so we can see more, we can have more acute vision. Parasympathetic usually causes our pupils to constrict. The larger the pupil, or the more dilated it is, the better we can generally see in dim light, and then the smaller it's more constricted in brighter lights. So they're usually round, they're equal in size. That size can be anywhere from 2 to 8 millimeters, even slightly smaller. But anisocoria, I'd mentioned that earlier. So something that there's greater than a 2 millimeter difference can be a concern. There's a lot of resources out there that you can consider. A lot of pen lights have a pupil gauge on the side, so you can kind of judge those. Over time, you'll get kind of familiar and comfortable with just kind of making a call on it. Also, a lot of your pocket guides that you have will have a pupil gauge on it that kind of helps you to judge it. Otherwise, there's things you can also tape up on the wall, the ambulance, or a laminated card or something. So unequal pupils usually a sign of, like I said, a structural issue within the brain. With the dim, you want to dim your bright ambient lights to note the size of the pupil. So we don't want there to be a lot of bright light when we're going to assess this. So sometimes you shield their eyes with your hand. Sometimes you ask them to shut their eyes for a minute or so and kind of shield over the eyes to reduce the amount of light that's getting to them. And as they open the eyes, you will then make a judgment and you take a look at it. When we are assessing those pupils, you're going to want to briefly shine the pen light into one eye and then repeat the procedure for the other eye. Now, when you do this, shine the light in, say, the right eye. Note what it does. Take it away. Shine the light back in the right eye. Look at the left eye. See what it does. Does it constrict like the other one? Switch to the other side. Shine the light in the left eye. Note what it does. Take the light away and then shine the light back in the left eye again. And look at the right eye to see, does it constrict. So remember, the pupils are supposed to work together. So normal pupil reaction, the pupils are pearl. Pupil equal and react to light. We can also do PERRL, which is pupils equal round and reactive to light. And then on occasion, you will also see people documented as perla, where they add an A on the end. The A means accommodation. In most cases, we are not really checking accommodation in the field. So if you don't know what checking accommodation means, you should not be documenting A on the end of that. Accommodation is watching the pupils move and change size as you kind of do some tricks in front of their eyes. So usually you can take your pen light after you've shined the light in the eyes and checked for the reactivity, take the pen light and move it in kind of an H pattern or a star pattern, and then move it in and out. So we're watching the eyes as they move and follow the object, and then as we move the pupil or the device inward and then back outward again, they converge and diverge, and the pupils will change size as this device gets closer or further to them. You can do the same thing with your finger, but that's accommodation. Most people don't actually check accommodation, so they are probably incorrectly adding an A on the end. Pupils will typically dilate for fear, anxiety, shock, and dim light, and some stimulant drugs, not all, that stimulate the sympathetic nervous system. So when we're kind of under fire, under the gun, we see pupil dilation, whereas people with dilated and non-reactive or fixed pupils will be common in either cerebral hypoxia, very, very late signs of shock, and death. So you'll hear them on TV talk about, oh, the pupils are fixed and dilated. Well, that's because the person's dead. Constriction. Constriction is very common, of course, in bright light. The most common place that we see constriction in most of our patients is narcotic or opioid drug overdose. So the morphines, Talwins, Dilaudids, fentanyls, heroines, and the drugs that actually will respond to Narcan. And then the substances that stimulate the parasympathetic nervous system will also cause pupil constriction, because constriction is a function of the parasympathetic, where dilation is a function of the sympathetic nervous system. All right, I think that wraps up this section of the chapter. If you if you've continued on through this and are looking at monitoring devices again, I encourage you to go back to week 2. Week 2 had the information on the second half of this chapter, which was a lot of our diagnostic tools. So